Welcome back to another episode of This Week in Pulmonary and Critical Care Medicine. I'm your host, Dr. Aladdin Sagar. Each week, I share a handful of studies that are shaping the way we practice, distilled into key takeaways you can actually use at the bedside. Remember, this podcast is for educational purposes only. It's not a substitute for clinical judgment, but hopefully, it gives you sharper tools and fresher evidence to bring to rounds. This week we'll cover a massive retrospective cohort asking whether acetaminophen really reduces delirium in the ICU, a landmark phase 3 trial of inhaled GM-CSF in autoimmune pulmonary alveolar proteinosis, a multicenter study challenging the routine chest X-ray after thoracentesis, and we'll close with an eye-opening review of extracorporeal CPR for refractory cardiac arrest. Let's dive in. Delirium, one of the most dreaded complications in the ICU. It's not just confusion, it's fear, agitation, lost trust from families, and it predicts longer ventilation, longer stays, higher costs, and higher mortality. Now, could something as simple as acetaminophen make a difference? Somnath Bose and colleagues studied 17,818 ICU patients across nearly a decade. Roughly 30% received acetaminophen at doses of more than or equal to 2 grams per day, and about 30% of all patients developed delirium, diagnosed rigorously with twice-daily CAM ICU assessments. Here's the jaw-dropper. Acetaminophen use was linked to a 34% lower risk of delirium, adjusted odds ratio 0.66, absolute risk reduction 6%. Put another way, treat 17 patients and 1 may be spared delirium. And the more days covered by acetaminophen, the stronger the effect, until it plateaued at about 40% of ICU days. It makes sense. Pain and inflammation drive delirium, and acetaminophen can blunt both, without the deliriogenic baggage of opioids or benzodiazepines. But let's be honest. This was observational. Could it be confounding? Absolutely. Maybe clinicians picked acetaminophen for patients already less fragile. Still, the signal is strong, dose-responsive, and compelling. At the bedside, it argues for making acetaminophen part of multimodal analgesia. It's cheap, safe, and potentially protective against one of the ICU's most harmful syndromes. But we urgently need a randomized trial before we call it definitive. Autoimmune pulmonary alveolar proteinosis is rare, but devastating. Patients literally suffocate under accumulated surfactant because autoantibodies disable GM-CSF. For decades, our only option has been whole lung lavage, invasive, exhausting, and temporary. Enter the Impala 2 trial. Researchers randomized 164 patients with autoimmune PAP to daily inhaled molgramostim versus placebo for nearly a year. Results? DLCO rose 9.8% with molgramostim versus 3.8% with placebo at 24 weeks. At 48 weeks, the gains not only persisted, but widened. Quality of life scores improved by over 11 points, well beyond clinically meaningful. And safety? Reassuring. No red flags. This is the first time we've seen a drug improve both lung physiology and how patients actually feel in autoimmune pulmonary alveolar proteinosis. It won't replace lavage tomorrow, but it may reduce how often patients need it. Of course, questions remain: durability, cost, and whether payers will embrace it. But still, for this rare disease, this is a milestone. Thoracentesis is one of the most common procedures we perform, and one of the safest when done with ultrasound guidance. But what about after the procedure? Traditionally, we order a chest X-ray to confirm lung re-expansion and exclude complications. It's so routine that it often feels unquestioned. The Evacuate study, a multicenter trial, directly compared post-procedure ultrasound to chest radiography in 145 patients with free-flowing effusions. Every patient had both, ultrasound immediately after, and X-ray within 4 hours. Here's what they found. Agreement between ultrasound and X-ray on whether pleural fluid was completely evacuated was outstanding. Agreement coefficient 0.93. Agreement on effusion size was substantial, with a kappa of 0.64. When 3 blinded reviewers assessed ultrasound images, inter-observer reliability was excellent at kappa 0.81. Roughly half of patients had evidence of trapped lung, again, reliably detected by ultrasound. So what does this mean in practice? Ultrasound at the bedside not only spares patients the radiation of a chest X-ray, but also gives you immediate answers without waiting for radiology. It avoids delays in patient flow, especially in resource-constrained systems where X-ray availability can lag. Importantly, ultrasound isn't just about confirming drainage. It also helps identify complications, residual loculated effusions, incomplete evacuation, or even pneumothorax, if you know how to assess lung sliding and M-mode artifacts. The study supports a paradigm shift. Instead of ordering routine X-rays, we should trust the ultrasound in most cases. That said, X-ray still has a role. When ultrasound windows are poor, when there's clinical suspicion of pneumothorax that ultrasound can't confidently exclude, or when unexpected pathology needs to be ruled out. But as a default, this trial strengthens the case for ultrasound as the first line and often only post-thoracentesis check. Bottom line, if you're comfortable with ultrasound, you can safely drop the routine post-procedure X-ray. That's faster, safer, and evidence-based. Cardiac arrest is one of the most difficult scenarios we face. The stakes could not be higher. Out-of-hospital survival, still less than 10%. Even in hospital, despite all resources, survival hovers between 15 and 30%. And after 30 minutes of CPR, meaningful recovery is almost non-existent. That's where extracorporeal CPR, or ECPR, comes in. VA ECMO during active resuscitation, not just to get a pulse back, but to restore circulation, restore oxygen delivery, and, most importantly, to give a real chance at survival with intact neurological function. This Lancet Respiratory Medicine review pulled together the best evidence we have: randomized trials, registries, and meta-analyses. These trials included the ARREST trial, suggesting that in refractory VFib, survival to discharge was 43% with ECPR versus 7% with standard CPR. That's remarkable, a number needed to treat of only 3. The Prague OHCA trial, showing neurologically intact survival at 180 days, 32% with ECPR versus 22% with CPR. Underpowered, yes, but the signal was clear. The Inception trial, a multi-center study across the Netherlands. It showed no significant benefit, but cannulation delays, often beyond 20 minutes, likely erased the advantage. Pooling the trials sharpens the message. In shockable rhythms, favorable neurological survival climbed from 28% with CPR to nearly 47% with ECPR. The number needed to treat? About 5. Meta-analyses show consistent reductions in mortality and neurological injury, but only in systems that are fast, coordinated, and highly optimized. So, who truly benefits? Younger patients, under 65 to 70, witnessed collapse with immediate bystander CPR, an initial shockable rhythm, and critically, cannulation within 60 minutes. Outside these parameters, unwitnessed arrests, asystole, prolonged no flow, the outlook is grim. And the risks are substantial. Major bleeding in up to 40%, limb ischemia in 5 to 15%, strokes or intracranial hemorrhage in 5 to 7%. And even with ECPR, most patients still don't survive. The therapeutic window is razor thin. Costs are staggering. In the US, initiation through discharge averages $75,000 per patient and well over $100,000 per survivor. In Europe, one trial estimated 22,000 euros in the first year, with only a 1 in 3 chance of being cost-effective. So here's the take-home. ECPR is not ready to be standard everywhere. But in highly specialized centers with trained teams and streamlined logistics, it can mean the difference between certain death and survival with a meaningful life. So, that's the bigger lesson. The future of ECPR isn't just about the machine, it's about the system. Fast, efficient, disciplined systems that can deliver this therapy when seconds matter. That wraps up this week's update. If this was useful, share it with your colleagues, fellows, or trainees. Staying up to date is tough, but together we can make it manageable. This is Dr. Aladdin Sagar, signing off from This Week in Pulmonary and Critical Care Medicine. Stay sharp, stay evidence-based, and I'll see you next week.